itself, it's extremely important to understand that the exercise capacity is critically related to transfer the gases, the oxygen, between your respiratory system via the cardiovascular system into the tissue, and vice versa, to get rid of the carbon dioxide which is produced in the muscle and in the body. So the test itself gives you an information about several what at the tip of the mask is the oxygen and carbon dioxide. However, it reflects directly what happens at a cellular level, as well as what happens in your lung with the tissue different, and what happens with the transport of these gases in the blood system. And we will try to explain to you later on in the case how you can utilize different parameters to see if there is a limitation of the exercise, in which of the systems you could look for a problem. So when you start an exercise, the sources of energy supply vary during the time. So in the first minute, the source of your energy, which the mechanical energy, is your hydrolysis of your roughly second or 10th minute, depending on the capacity of the patient. It's usually the oxidation of your glucose or fatty acids which delivers your ATP. Once your oxygen supplies cannot meet your demand, the metabolism to the anaerobic metabolism, a less efficient way of producing your ATP. This is a very simple way of showing how you produce energy. So on the left side of the slide, you've got the glucose, which is transported on a cellular level at the cytoplasm. Glycolysis is broken down to pyruvate, and then if you get oxygen, you go into the mitochondria, where it undergoes the oxidative phosphorylation. That's phosphorylation to phosphorylate your ADP to ATP. However, if there is lack of oxygen, the body switches over to the lactic acid way, which is a way less efficient way to produce your ATP. I didn't put here, but basically in a very similar way, you will have fatty acid, which undergo beta oxidation, and at some point are broken down to acetyl-CoA, and this then undergoes the same electron transport chain, and in Krebs cycle, then electron transport chain at the phosphorylation way. The lactic acid, if it gets stored, gets then buffered by carbonate and produce water and CO2, and this is your excessive CO2 then the rise later during your exercise. So when is a CPEX helpful? In cardiac patients...
Con, sorry to interrupt, your voice is breaking up quite a lot.
Can you hear me now? It's a bit better. I hope I'll get a little bit better internet. Can you hear me?
Yeah, I can hear you, Con, but as you speak complex stuff, the voice gets a bit broken up. So, not sure.
Okay. I hope I'll get some better connection in a moment. Yeah.
Yeah.
So, there are four important roles when you can use CPEX. One is to establish whether the exercise the patient has got exercise limitation or not. This is especially important to know whether some patients are breathlessness truly due to deconditioning or truly due to underlying pathology. This goes to the second point where you can assess the underlying mechanism of breathlessness. And this can guide you towards the underlying pathology, whether the limitation lies in the respiratory system, in the cardiovascular system, or other causes. I'll go over this later in detail. Another very important use is monitoring of functional status. And this is especially applies in patients with advanced heart failure, such as
Dr. Constantine. Dr. Constantine, sorry to interrupt you. Your voice is not clear, it's breaking. Is it possible for you to use a mic and headphone that will make the voice better? Or you can switch off your video. You can make your video off and go with your audio alone.
Let me try with the headset. And I'll try to switch my video off here. Okay, can you hear me better now?
It's better. It's better. Yeah.
Okay. Is it better this way? Okay, so I'll continue this way without a video. So very quickly again, the reasons why we should do a CPEX is first to establish whether a patient has got through exercise limitation. Second, to establish what is the underlying mechanism of the limitation. Third, monitor functional status, especially in advanced heart failure, such as heart transplant patients, or patients with adult congenital heart disease and so on. And the last but not least is CPEX has been shown to carry excellent prognostic value in patients who undergo large surgeries, myectomy in lung cancer patients, or abdominal aneurysm repairs, or so on. So I'll just jump over there. Just to mention, CPEX plays, for example, a really important role, or can play important role in cardiac ischemia detection. And this is not a well-known fact. And I think Dr. Parasuraman will later show you some case where you can, with that, if you add your ventilation and gas exchange to your normal exercise treadmill test, you can incrementally increase the information you get and improve the sensitivity and specificity of the test. There are some contraindications. The important contraindications are exactly the same as for any other exercise test, being very recent acute myocardial infarction, recent acute myocarditis, severe symptomatic aortic stenosis or uncontrolled heart failure with pulmonary edema, uncontrolled arrhythmia, dissecting aortic aneurysm, or severe hypoxia. So the combination you get, okay, I hope you can hear me because it shows me the connection is unstable, but the combination you get is exercise ECG, where you get all your normal information with symptoms, hemodynamics, arrhythmia, OSD changes, but additionally you get the gas exchange changes and ventilation. This can be useful and has got some advantages if you compare it, for example, to other non-invasive tests, seeing ischemia such as myocardial perfusion scans or even MRI, to a degree when you have artifacts which can affect imaging. I hope you can hear me because I hear some funny noises in the back. Can you just...
it's definitely better, Dr. Constantine, now.
Is it better? Okay, good. So I'll just continue. So, for example, if you get patients who have a branch block or balance ischemia, some non-invasive imaging tests assessing for reversible ischemia have their limitations, whereas the CPEX test hasn't got these problems. So this is an example of a very typical protocol which we used in Aberdeen during our research. And this protocol is quite applicable to most of our patients. Basically, this is a treadmill test. The patient starts at 2 kilometers per hour, zero gradient, and then there is an increment of 1% incline every minute. And this way, the most patients will exercise for roughly something between 4 and 5 minutes up to about 10, 11 minutes, which is enough to get a nice slope for interpretations in the VO2 and in the carbon dioxide. So before we go into the interpretation, I have to understand also a little bit about the nomenclature. And there are not too many parameters which you have to understand. And I'm sure most of you know most of these. So just to the VO2 is oxygen uptake. And this is basically the amount of oxygen which is extracted from the gas which is inhaled and measured at the tip of the mask. And this is then this is then plotted again in my class, which in the presentation. It is expressed as milliliters per kg per minute usually. And in the same manner, you can measure the amount of exhaled carbon dioxide, which is the VCO2. An important parameter which we usually measure is a peak VO2. And there is something similar, which is also called VO2 max. They have got slightly different connotations. The VO2 max is the maximum oxygen uptake. But usually you can really you obtain this only if you do repeated tests. And it's only achievable in high elite athletes who at some point when they exercise, where the oxygen uptake plateaus. So usually in our patients who are limited, while they go up and don't really reach much plateau, we call this peak VO2, and this is an important parameter for our test interpretation. The peak VO2 is reliable only if the patient exercises to a good level, so it does not perform a suboptimal test, and to be sure that somebody has exercised to a good level, you need to get the next parameter, the so-called RER, the ratio of carbon dioxide output to oxygen take, more than 1.15. So this is a peak ratio between VO2 to VO2. Another important parameter. Yes,
Dr. Constantine, sorry to disturb you. The voice again got kind of worse. Is it possible for you to use a kind of mic?
Yes, I've got just a moment. I've got a microphone.
Sir, there is not cleaning, sir.
I've got a microphone just next to my mouth. Can you hear me better, or?
Yeah, now it's better here. But when you talk, when you start your presentation, somehow it's not clear.
I have. I reached my and I do have now the microphone.
A lot of artifacts come, artifactual sounds I could hear.
Yes. Can you? I'm not sure that I do have a headset, but I'm not sure the internet connection is maybe a little bit weaker. But unfortunately,
okay, that's okay. That's okay, Dr. Constantine. That's okay.
To speak as near to the microphone as possible. Yeah. So good. The next one is the part is called mid ventilation, the VE, which is basically the amount of which is ventilated in a minute, and usually we take the maximum the minute ventilation in the end of the exercise. Then there is another parameter which is called maximum volume ventilation, which is a calculated parameter which we obtain from a spirometry, which is formed before we start the CPEX. And we then multiply the FEV1 by 40. Then this is used to calculate the so-called breathing reserve, which is the last parameter, which is basically just the difference between the maximum ventilation and the minute ventilation. And there is the last of these important parameters, the anaerobic threshold. And this is basically behind the exercise when the anaerobic metabolism kicks in, the moment when the oxygen supply does not meet the demand. All of these parameters have a meaning. So I mentioned before, the respiratory exchange ratio
stands for the effort. And basically, it's very important to see that if somebody achieved an R which is less than 1, then basically the test is meaningless. You know that the peak VO2 and lots of these other tests will not be interpretable. The peak VO2 tells you about the limitation. Is the patient limited or not? There are internationally well-published tables which are gender and age specific to what should a person achieve. For example, a younger middle-aged man who is untrained, you would expect to have a peak VO2 somewhere between 35 and 45 milliliters per kg per minute. But high elite athletes can achieve up 60 to even 80 milliliters per kg per minute, such as Tour de France cyclists or so. Most of this VO2 is predetermined genetically by genetic predisposition. However, it is said that about 25% you can improve by chronic aerobic exercise. I mentioned already the breathing reserve, which is the calculation from your maximum voluntary ventilation minus your measured minute ventilation. If this is abnormal, if this decreases, then your limitation is due to a respiratory problem. There's one caveat, and this is in high elite athletes who can exercise and doing higher workload despite that the oxygen uptake doesn't go up. And this is by a way that they so-called eat into their respiratory reserve. Nevertheless, they would not be limited. Peak VO2 is supernormal usually. The VE-VCO2 slope is called ventilatory efficiency. It's an angle which I'll on the next slide how it can be measured. Has got great prognostic importance. And this is abnormal. If this is abnormal, the problem usually lies in the cardiac or respiratory system. And it implies that there is some kind of a ventilation perfusion mismatch and usually increased pulmonary pressure. So it can occur both in heart failure, but also lung problems or pulmonary hypertension. I mentioned already the anaerobic threshold. So oxygen uptake, which at anaerobic threshold is low, implies that there is a problem in the cardiac system or there is pulmonary hypertension. And, one last parameter which I think is quite useful to know is so-called oxygen pulse. The oxygen pulse is basically your oxygen uptake corrected for your heart rate. So this is also then plotted against the time as such. And it's an indirect measurement of your stroke volume, and hence it can indicate what output. So these are examples of how such graphs look like. So this is your time of the exercise, and in the red there is the oxygen uptake, and which increases as the exercise goes, and parallel blue, that is the carbon dioxide production. And as you can see, when it comes into 7.5 minutes, suddenly the carbon dioxide production increases much steeper compared to the oxygen consumption. This is the time when the anaerobic threshold kicks in. And this is one way how you can measure the anaerobic threshold. It is not very exact science, it has to be said, and it's often criticized in some papers. There are other methods how you can measure it. One of the methods, for example, is V-slope method, where you just plot your V-slope on the y-axis and your VO2 on the x-axis. And at the beginning, when you've got your aerobic metabolism, it's quite a straight line, and at some point, it's much steep, and this is where your anaerobic threshold is. The last graph is just to demonstrate how you can, what actually stands the metabolic efficiency, so-called VE-VCO2 slope. So this is basically an angle which is plotted from the start of your of the exercise and increases and is measured up to the point where threshold is, and if the angle is small, so it's less than 30, then usually it's normal. If it becomes higher, it's more than 33 or 34, then it implies that there is some problem with the ventilation perfusion. So the application in CPEX are variable, and I've already mentioned it can be used in advanced heart failure. So for example, if you have got a peak VO2 of less than 12, or of beta blockers less than 14, and there is no improvement on optimal medical therapy, then this indicates very poor prognosis, and these patients should be considered for heart transplant. We know if the VE/VCO2 slope is high and the VO2 at anaerobic threshold is low, this can increase your mortality significantly. The abnormal CPEX in multiple cardiac abnormalities and cardiomyopathies. For example, lots of studies have shown that if you got headphones, you get much abnormal VCO2 slopes compared to heart disease or deconditioned patients. Sanjay Sharma showed some ideas on comparing hypertrophic cardiomyopathy to athlete's heart in both mild LVH, but there are strikingly different responses on CPEX. And as I mentioned before, it's frequently used by anesthetists who want to decide whether a patient is fit enough to undergo an open operation and what is the or whether they should rather have a non-invasive treatment, such as radiotherapy, chemotherapy, so on. And same is for major abdominal vascular surgeries. The most prognostic values, again, are these, actually the last two parameters. And there are multiple surgical operations which had described CPEX with its prognostic value. Specifically for cardiac patients in valvular heart disease, it's known that, for example, exercise-induced MR or pulmonary heart disease patients have abnormal CPEX results. And if you, for example, correct pulmonary valve disease, your ventilatory efficiency, the VE/VCO2 slopes improve quickly, and a few months later, the VO2 goes. There is quite some intriguing information about prognostic value in asymptomatic severe aortic stenosis. This is still something which on occasions can be difficult to decide at what stage should we operate on patients with severe aortic stenosis. They are completely symptomatic. This is quite an old, was a small pilot study in 2014, but it's used in some AHA guidelines on the use of CPEX, where they divided the patient with asymptomatic severe aortic stenosis into groups. And this was after about 6 months, they looked whether they developed symptoms or not. The symptoms were either heart failure, syncope, or mortality. So this was the group 2, or if they remained asymptomatic, they became group 1. And they looked then in the previous demographics and tests, and the one really striking difference was exactly in the VE/VCO2 slope, which was strongly abnormal in ones who became symptomatic. This is another study, unfortunately, from a Mayo Clinic group, last year, published only as a poster, so I hope it will be at some point a full paper. But they looked at patients again with asymptomatic severe aortic stenosis who underwent CPEX and looked at their mortality. And it's striking that the red one, the group, where the patients were limited, so despite running officially asymptomatic, but on CPEX were limited, if their VE/VCO2, if they did not receive AVR, half of them were dead in less than 2 years. On the other hand, for example, if they were limited on the peak VO2, however, their ventilatory efficiency slope was normal, they did not receive AVR. Most of them were alive. So, very simple recipe, which with suggested a few years ago was at first, when you feel the exercise test, you have to look whether the patient is truly limited. For this, the patient has to achieve a good exercise, which you see if you've got your ARIA of more than 1.15. And then you look if the peak VO2 is less than 85%. The next stage is the next thing is to look at the spirometry and the breathing reserve. If these are normal, then it means there is lung limitation. Usually these patients desaturate during exercise, and it implies they've got primary lung disease. Usually they have a high VVC2 slope. If the spirometry is normal and the breathing reserve, then it's not a lung. Then the next thing you look at is the ventilatory efficiency slope and the oxygen uptake at anaerobic threshold, whether it occurs early or not. If these two are normal, then it's usually that the patient is usually just fat and deconditioned, and there is usually no desaturation. If these two are normal, then it's usually cardiac impairment, or if there is additionally desaturation during exercise, and there is pulmonary hypertension. This pathway is not foolproof completely, so I sometimes would advise that you use other pathways as well. There is quite a nice paper from Milani in 2004 in Circulation, which can help you sometimes. There are plenty of other pathways, but some of them are really over-complex. And I think just as note of caution is, this test should not be used as the sole test, but it is just a piece of the jigsaw. You look at DECO, you look at a pulmonary function test, maybe at coronary angiography information and other tests, and then make your diagnosis. Very quick, just a typical report. This was a patient we saw in Aberdeen with hypertrophic cardiomyopathy, who had already a CRTD, had an NYHA class 3 to 4. So this patient had hemodynamic response where the heart rate as well as the blood pressure did not improve. It even dropped a little bit, the blood pressure. And his peak VO2 was very low for a 34-year-old man. Peak VO2 was 12. However, if you look at his ARIA, he actually did really push himself. So his ARIA was 1.2 and his saturations were normal, so there was no problem in his lungs. His ventilatory efficiency was grossly abnormal at 58. So the conclusion at the end was that the patient had severe exercise limitation with low peak VO2, and there was chronic incompetence and failure to increase blood pressure on exercise. So the cause was heart failure with markers of poor prognostic outcome. So this is just some further reading. I'll go back here. This is very useful AHA guidelines on recommendations for the cardiopulmonary exercise testing in specific patient population, and especially quite some information on cardiac patients. And there was a focus update back in 2016. This is the paper we've written a few years ago, where you have also this this pathway how to report. And anyone who wants to go into detail is advised to look at Wasserman, which is like the Bible of cardiopulmonary exercise. I will stop now, and my apologies if you did not hear me well. I'm really sorry. I did try it before the internet connection. I hope that you've had at least a little bit. Can you hear me now, Satish? I'll pass over to you.
Yeah, thank you, Dr. Constantine. Dr. Manohar, sir, would you like to proceed?
Upati, we will have questions at the end.
Okay, sir. Dr. Constantine, that was a great talk, though we had a few glitches of sound.
I'm very sorry for this.
Yeah. Yes.
Dr. Manohar, sir, please take over.
Dr. Satish, you can
Yes.
you can share your screen, sir.
Yes, sure. Thank you. Sorry, how do I did it earlier? How do I share my screen, please?
Sir, you can. I think he has to stop sharing from his side.
I did stop it.
Yes.
I did stop it. Yeah. I did stop. Yeah.
Okay,
Yes, sir.
thank
Now
you.
you can share your screen, sir.
Sorry, how did you share your screen, Con?
Sir, the right corner, just besides the video button, there is one share content. No, sir. Can you see that the green colored?
Share screen, yes, yes.
Yes, yes, sir.
Okay. Yes, thank you.
Yes, sir.
Thank you very much. I appreciate that. Thank
Sure,
you.
sir.
Right, okay. Okay, can you hear me okay?
Yes, yes, sir.
Thank you, thank you. Thank you for the whole team in Sriha, Professor Thanikachalam, Vice Chancellor, Dr. Ramamurthy, Professor Jason Murthy, Professor Manohar, Professor Muralidharan, and Professor Bhupati for inviting us. So thank you so much for the opportunity. Now, I'm just going to, we had a chat about the presentation, so there will be some overlap, and that is intentional overlap. And please shout out any questions as we go through, otherwise this can be quite dry. Anyone, any questions? Because I know we don't do cardiopulmonary exercise testing in India and generally in cardiology everywhere all over the world, and in India especially. So any questions, please shout out. And also I'm on chat as well, and there is a chat button on the bottom, and you can chat, and Bhupati can, or one of Professor Ramamurthy can, or Professor Bhupati can give me a shout to stop and have a chat. Now, I know that we don't do cardiopulmonary exercise testing regularly, so I've got a picture here. It can be done on a treadmill or a bicycle. So your aim is to do an incremental stress test so that the patient exercises for about 10 minutes or so, not for 20-30 minutes, because when the patient exercises on a low gradient or a low resistance on a cycle, they exercise for a long time, and they stop the test by muscle fatigue due to cramps, due to electrolyte or electrolyte imbalance or dehydration. We don't want that. We want them to stop because of breathlessness, because of the heart or the lung, so that we can identify what's happening when they stop the exercise. So an exercise protocol is planned so that they exercise for about 10 minutes or so approximately. So here we have a gentleman on a bicycle, resistant exercise. So you start either, there's two types of protocol, a ramp or a step protocol. Ramp very gradually. So resistance increases, for example, 5 watts every 10 seconds or 2 watts every 10 seconds. And then or the step protocol, which is 25 watts every couple of minutes. So that it'll be running at 25 watts, and after a couple of minutes increases to 50 watts or something like that. There are advantages and disadvantages in both. Now, this is a bicycle stress test. And whenever I speak to cardiologists about cardiopulmonary exercise testing, there is a lot of anxiety. Oh, I haven't seen it, or I haven't done it. But actually, it's what we do routinely and a little bit in addition. That's about it. Now, this gentleman has the ECG leads here in the chest. You can see that. That's normal ECG lead that we do for exercise stress testing. And then he has a blood pressure cuff in the left arm, as we normally have for our exercise stress test, treadmill test. There are only two additions. One is there is a face mask here. The patient is wearing a face mask, and there is a gas sampler that takes a sample of gas, a sample of the oxygen consumed and the carbon dioxide produced for analysis every breath. And then what is hidden here is a saturation probe attached to the right ear. with the white thing that dangling on the right side of the ear. So only 2 attachments extra, which is a face mask with a gas analyzer, and then you have a saturation probe on the right ear. So what is the aim? So the aim is the primary function of cardiovascular and respiratory systems is to support cellular respiration. And by measuring the oxygen consumed and the carbon dioxide produced, you get a good idea about what's happening at a cellular level. This forms the basis of cardiopulmonary exercise testing. Now, because especially I know that we have, not all of us have seen tests, so I'm just going to play a video, and I hope you can hear it. So here is an elderly woman doing a cardiopulmonary exercise test on a treadmill. So again, she wears a belt on her hips, which is the ECG leads attached, and then she has a blood pressure cuff, saturation probe on the left ear, and then has a mask to measure the gas exchange. 2 screens instead of 1, of course, 1 for the ECG and 1 for the gas exchange. So the initial couple of minutes we do is called the warm-up. So when we start the exercise, there is that expectation, that anxiety of the exercise increases the heart rate and the respiratory rate in preparation for the exercise. We want them to settle down, and hello, can you hear me?
Yeah, we could hear you.
Yes, sir.
Thank you. Thank
Yes,
you.
we hear, but the video disconnected.
Video is stopped, right? Okay, fine. So can you hear me again, and can you see the screen?
We can't see your screen, Satish, but we can hear
Not
you.
yet,
Okay,
not
fine.
yet, sir. We can
Apologies.
see your
Thank
face
you.
and hear you, but not your screen.
Okay, sorry, I'll just do that again. Yeah. And how about now?
Yes, sir. Now we can see, sir.
Okay, fine. So I'm going to stop the video there. So essentially, I mean, I'll see whether it be videos. It'll be fun to see how she does towards the end. Sorry, 1 second. I'll have to skip the video there. But it doesn't matter. I mean, you saw the most of it anyway, the video. So I'm going to crack on to the next slide. So I did cardiopulmonary exercise testing as a part of my research and for clinical purposes as well, and presented in a few meetings. We did a few publications on it as well. Now, what are the guidelines say? This is the last ESC guidelines on heart failure. So cardiopulmonary exercise testing is pivotal for assessing a patient for cardiac transplantation. The class 1 indication, like an ECG, like a echocardiogram and a chest X-ray. It's a class 2 indication for exercise prescription in patients with heart failure, and also patients with breathlessness is a class 2A indication. So it's a strong indications there. The heart transplant guidelines, the first essential criteria for listing patients for heart transplantation is cardiopulmonary exercise testing. So whether the ejection fraction is 10%, 15%, 20%, it doesn't matter. In my thought, it is not how the heart is doing on its own, how the whole body is responding to a diseased organ, that is the heart. How the whole body is responding, how functional the patient is, decides the prognosis of the patient. In complex situations in our specialty, like in a complex heart failure, complex congenital heart disease, where we don't know where the baffles are, where multiple connections are, where echocardiogram and MRI don't make any sense anymore. You want a much more wider, take a step back and assess the patient from a wider perspective. So that's where cardiopulmonary testing comes in. And that's why it is the first criteria for listing for patients for cardiac transplantation. Hypertrophic cardiomyopathy guidelines, it is a class 1 indication for symptomatic patients with hypertrophic cardiomyopathy, class 2A indication for asymptomatic patients. What is the other indication? We have all seen this before, 5 blind people looking at elephant from different angles and describing it their own way. Same thing happens when a breathless patient is referred to either the cardiologist or respiratory physician. If a doctor refers to me for a breathless patient, I'll go through the history and say, well, you have a family history, your father had a heart attack, or you smoked for a couple of years or something. I'll find something and I'll send the patient for echocardiogram and a CT coronary angiogram. Very likely, and they will come back as normal. And then I'll say to the GP, or I'd say to the doctor referring to me, I'll say, I'm not sure what entirely the cause of this man's breathlessness is. We can do some lung functions or whatever. Or I will send the patient to the lung doctor. The lung doctor will again look at the smoking history and say, I got the history. This is good. This is going to be obstructive lung disease. And he will do some spirometry and gas transfer or high resolution CT. And again, after that, we will refer him to somebody else. So the endocrinologist sees him, a renal physician sees him and says, oh, this could be renal tubular acidosis causing. So breathless patients need proper assessment. Sometimes there is no clues as to which one is likely, whether the heart, whether the lungs, whether the delivery system, the vascular system. So the cardiopulmonary exercise testing guides us in this regard. I want to introduce you to one. I know it's a bit boring on a Friday evening to listen to cardiopulmonary exercise testing, but I would like to have your attention for the next few slides, please. So we all get these reports, the treadmill test report, saying this patient exercised for 6 minutes or 7 minutes, achieving 8 or 9 metabolic equivalent, 8 or 9 METs approximately. So we all read through it. We probably didn't process what it is. So MET is a short form for metabolic equivalent. Metabolic equivalent is the amount of energy we consume, is a measure of the amount of energy we consume. While we are sat and not doing much, we consume about 1 MET of energy. When we start to walk slowly, we will consume 2 to 3 METs of energy. And when we do a fast walk, we'll be consuming 4 to 5 METs of energy. If we are running slowly, it will be 7 or 8 METs of energy. So that's what a MET is. It's a measure of physical activity. To produce 1 met, we approximately consume about 3.5 milliliter per kilogram per minute of oxygen. So when Robert Bruce standardized our treadmill tests in 1960s and 70s, he did cardiopulmonary exercise testing. So he will measure the amount of oxygen consumed, the amount of carbon dioxide produced for an average 70 kilogram man when he exercises on a treadmill on a particular gradient and speed. And then he will say, this is the approximate amount of oxygen you consume when you're running on a treadmill at this speed and this gradient. So that's what is used now to say this patient exercised for 7 minutes and then reaching approximately 8 metabolic equivalents. So again, it is the energy cost of physical activity. At rest, we need 1 met. 1 met is 3.5 ml per kilogram per minute of oxygen. And here is a report of a cardiopulmonary exercise testing. We measure it directly rather than assuming, because not all of our patients are 70 kilograms and all of our patients will be the normal patients. So here we measure it directly. So here you have the red box, you have a 24.2 milliliter per kilogram per minute of oxygen. This patient is consuming 24.2 milliliter per kilogram per minute of oxygen at peak exercise. That is 24.2 divided by 3.5 is 6.9 metabolic equivalents. So why is exercise capacity important? Why do we bother about exercise capacity? We have more sophisticated tests. We have got CT, we've got MRI, we've got everything, angiograms, pressure wire, OCT, in fact. Why is it important? Now, this paper from 2002 compared the prognosis of patients after treadmill exercise tests. So in the left-hand side graph, you have normal subjects with no history of cardiovascular disease. On the right-hand side graph, you have patients who have had proper cardiovascular disease, congestive cardiac failure, previous bypass, peripheral vascular disease. So if you see the normal subjects, those who exercised less than 5 metabolic equivalents, at 14 years, only about 40% survived, about 60% died. At the same time, if they exercise for more than 8 metabolic equivalents, your survival is more than 80%. So no history asked, apart from the cardiovascular history, nothing else asked, no other blood test done, nothing is done, only treadmill test. And here, the patients with cardiovascular disease, these are proper cardiovascular disease patients. Again, if you exercise for less than 5 meds, about 35% prognosis, more than 8 meds, about 70% prognosis. So in both groups, each metabolic equivalent increment in exercise capacity was associated with a 12% increase in survival at a 14-year period. If you if you're over 65, for each metabolic equivalent increase in exercise capacity, the survival was more than 18% over a 14-year-old period. Here again, the black bars are the patients with no cardiovascular disease, and the white bars are the patients with cardiovascular disease. So it doesn't matter whether you have heart disease or not. What mattered was the exercise capacity. We need to realize that when in 1960s and 70s, when exercise test was the sole test for ischemic heart disease, we did not use exercise tests for diagnosis of angina. Diagnosis of angina was made in the clinic with a history and examination. We used exercise for prognosis. So when patient exercise for more than 7 minutes in a Bruce protocol, or approximately 7 metabolic equivalents or more, there is no evidence that revascularization will improve their survival. That's what used in the recent ischemia trial as well. Anyone exercised for more than 7 minutes, achieving more than 7 metabolic equivalents, were excluded from revascularization. Still stands good. Then we started using it for diagnosis, despite its pitfalls. Patients with anemia, pneumonia, lung disease, right bundle bunch block pattern, on digoxin, atrial fibrillation. We started using it for everybody. And that's not the right way. It's not intended to diagnose coronary artery disease. The ST depression was just merely a function of reduced oxygen delivery. So what, again, re-emphasize what Dr. Constantin Schwartz said. So one of the problems we have in the treadmill test is the patient, often I get the test saying this test is inconclusive. If the patient exercises for 7 minutes, I'm not sure daily what's going on. That's what the physiologist says. So one of the things is, has the patient exercised to their maximum capacity? Or did they stop because of tiredness, because they didn't want to go further, because the physiologist didn't push them? So in the when they do a cardiopulmonary exercise testing, there's a measure called respiratory exchange ratio. That's the ratio of the carbon dioxide produced to the oxygen consumed. If this ratio is more than 1.1, you can be fairly sure that this patient has done a fairly symptom-limiting maximal exercise test. So this test can tell us whether the patient has done a maximal test or not. Exercise time, ECG, blood pressure, and heart rate, we get that all from our routine treadmill tests. Oxygen saturations at rest and peak exercise, we don't get that in normal tests. We get that in cardiopulmonary exercise test. Oxygen consumption and carbon dioxide production, we don't get that in normal test. We get that in cardiopulmonary exercise test. And the other important parameter is, when does the anaerobic metabolism start? Because in heart failure patients, they resort to anaerobic metabolism very early. The oxygen pump to the heart is not very good, so the delivery of oxygen is not very good. Therefore, the consumption of oxygen is not very good because the delivery is poor. So the anaerobic metabolism sets in very early in exercise. So we can find out when does the anaerobic metabolism begin during the exercise test. We can do it in treadmill tests. If you do an arterial line and start measuring their lactate every minute or every couple of minutes, we can identify when the lactate starts to build up in the body. That's where the anaerobic metabolism starts. In cardiopulmonary exercise testing, we don't need it. We can just see how much carbon dioxide is produced, and that will give us a clue when the anaerobic metabolism starts. So I'm going to give a brief summary before I go on further. Treadmill exercise tests and CPEX are very much the same. There is, exercise testing should continue to be the heart of cardiology practice in my view, because a lot of times I tell the patients, I'm not entirely sure what is happening, because you came in with a small troponin rise or whatever, but your coronaries are normal. But you did a treadmill test, a fantastic treadmill test, it's all normal. So your prognosis is very good. Sometimes we don't know the diagnosis, but we can reassure the patients the prognosis is good. CPEX gives useful information at low risk. You're not doing, this is not an invasive test. And learning basics of CPEX is not that difficult. Now, any questions for me? Because it can be very boring if I just continue without asking any questions from the panel, or from moderators, please, or from the listeners.
Very nice talk, Parshraman. Very nice to hear from you. I thought Dr. Dhanikachalam sir can share some of his experience with testing in an asymptomatic population and in his first study. Sir, Dhanikachalam sir.
There's some connectivity problem there. There is some
not connected probably.
Satish, would you like to proceed?
Okay, I'll proceed, and then of course, please ask any questions, because otherwise it can be boring, as I said. So as Con said, a lot of terminal. This is one that the cardiologists don't like hate to interpret CPEX is the terminologies that we use, but forget about the terminology. It's all we know. When someone says VO2, it is the oxygen consumption. The V stands for ventilatory measured. We are not measuring it directly, but we're measuring it by the amount of oxygen that goes into the body and comes out of the body, and then we calculate the amount that is consumed. So V stands for ventilatory. So VE, means ventilation, VO2 is the oxygen consumed, VCO2 is the carbon dioxide produced. So we know most of the terms, we are just making it a little bit complex. A little bit on oxygen carbon dioxide kinetics. So on the left-hand side graph, you have oxygen on the red line plotted against time. So when we start to exercise, once the warm-up period is over, then there is a steady increase in oxygen consumption as long as we increase the gradient or the resistance of the test. Depending upon the treadmill or the bicycle, the oxygen consumption steadily increases. This is initial period. In the initial period, this is mainly by the increase in the stroke volume, and later by increase in the heart rate as well. So the oxygen consumption steadily increases throughout the exercise, and towards the peak, it plateaus slightly. This is called the peak oxygen consumption. The amount of oxygen consumed at the peak test is called the peak VO2, or the peak oxygen consumption. Here on the right-hand side graph, you have a real-life, test graph here. The red one is the oxygen consumption in this graph against time in the x-axis. And then the oxygen consumption steadily increases, and then it plateaus towards the peak. And you will average it over the last 30 seconds, and you would say this is the peak oxygen consumption for this patient. In this patient, you would say it's about 1,800 milliliters per minute. Then you have to calculate to the kilogram as well, so milliliters per minute, and depending upon whatever the weight of the patient is. So the initial source of energy, the green, again going back to the left-hand side graph, the green bar shows the initial source of energy is from the already stored source of ATP. But then for the rest of the heavy exercise, we need aerobic metabolism by aerobic metabolism of glucose and fat throughout the exercise to supply most of our energy. In a symptom limiting exercise, when we increase the gradient of the speed of the exercise, we need furthermore source of energy, and that comes from the final heavy exercise. We need a little bit more energy, and that comes from anaerobic metabolism. That's in the final phase of the exercise. So what does the carbon dioxide do? The carbon dioxide production runs parallel to the oxygen consumption, just below, but parallel to oxygen consumption, up to a point beyond which the carbon dioxide production increases disproportionately to the oxygen consumed. We can tell that this is the point where additional carbon dioxide is produced, and this carbon dioxide is produced by anaerobic metabolism. And then at the peak exercise, the carbon dioxide production exceeds the oxygen consumption. So this point is the anaerobic metabolism point, where the anaerobic metabolism starts. Again, in this graph and the real life graph, it's probably this point where the two lines start converging. This is the anaerobic threshold. So if the peak oxygen consumption is less than 85% of predicted, it tells us there is a problem in one of these systems. Either there is a problem with the cardiovascular system, lungs, blood anemia, muscles, like in myopathies, deconditioning when the patient is post-operative or not just exercising very well. So this in these graphs, the left first graph shows the oxygen uptake in a normal person, where the oxygen uptake steadily increases and plateaus towards the peak. In heart failure, it never takes off. It's quite flat. And then obviously the peak oxygen consumption is less than 85%, much lower than this. While in coronary ischemia, it goes on suddenly, it goes on steadily, as you would expect, until a point where cardiac dysfunction sets in due to when the coronary ischemia induced cardiac dysfunction sets in, the oxygen consumption becomes flatter, abruptly flatter towards the peak. as I said, respiratory exchange ratio is nothing but the carbon dioxide produced, is the ratio of the carbon dioxide produced to the oxygen consumption. It's usually less than, it is always less than 1 throughout the exercise. And towards the peak, it is more than 1. The carbon dioxide production exceeds the oxygen consumption. And you know when the respiratory exchange ratio is more than 1.1 that this patient has done an adequate test. This is an advantage compared to our routine exercise test where we don't exactly know whether the patient has reached peak exercise or not. There are various ways of calculating anaerobic threshold. As Dr. Schwartz said, it's the point where the oxygen consumption, where the carbon dioxide production becomes disproportionate to the anaerobic threshold. So again, going back to the anaerobic threshold, this is the point where the carbon dioxide production takes off disproportionately. In patients with heart failure, patients with pulmonary hypertension, this anaerobic threshold is much earlier. Their ability to deliver oxygen to the tissues is poor, hence they resort to anaerobic metabolism very early. So either the patient has a heart problem, congestive cardiac failure, pulmonary hypertension, blood problem, severe anemia, again delivery of oxygen to the tissues, muscle problem, mitochondrial myopathies, where although the oxygen delivery is good, their ability to conduct aerobic metabolism is poor. So how is it calculated? You know, I told you about anaerobic metabolism, how to identify the anaerobic threshold or identify when the anaerobic metabolism sets in. How do we calculate it, or how do we know it's early or not? For a normal person, the anaerobic metabolism sets in at about 50 to 60% of exercise. In athletes, it's quite late. The anaerobic metabolism sets in quite late, 70 or 80% of during exercise. Now, in this patient, this is real patient results here. It shows the oxygen consumption in milliliters per kilogram per minute at anaerobic threshold, otherwise called lactate threshold. The oxygen consumption is looked at. It is 15.69 milliliters per kilogram per minute, while the predicted oxygen consumption is 38.75 for his age and sex. So we look at these two parameters, the oxygen consumption at anaerobic threshold and the predicted predicted oxygen consumption at peak exercise. The ratio of that is calculated, and we know, and we can tell in patients with where the ratio of the oxygen consumption at anaerobic threshold to the predicted peak oxygen consumption is less than 40%. It suggests a cardiac limitation, otherwise pulmonary hypertension or mitochondrial myopathy. So essentially, an early anaerobic threshold means there is a problem in aerobic metabolism due to either delivery of oxygen or utilization of oxygen for aerobic metabolism. So a couple of other parameters. Again, we only measure, all we need to remember is, although there are too many terminologies here, we are only measuring a few parameters: oxygen consumed, carbon dioxide produced, and oxygen saturation. These are the only three parameters we are measuring in addition to our normal treadmill test. Oxygen consumed, carbon dioxide produced, and oxygen saturations by the finger or ear probe. These are only three parameters we use. So we can be, everything else is derived from that. Graphs plotting one against another. So now, oxygen pulse is the ratio of the oxygen consumed to heart rate. It is a surrogate for stroke volume. In the left-hand side panel, the oxygen pulse is in blue, and the heart rate is in red. The left-hand side panel, you can see the oxygen heart rate goes up steadily, as you would expect, and then the oxygen pulse goes up steadily as well. The right-hand side panel, you have a patient with heart failure, where the heart rate goes up, which is in red, and the oxygen pulse does not go up, which is quite flat, indicating there is a problem with cardiac pump.
Sorry, Satish.
Yes.
I have a question for you. Can you go back to the previous one?
Yes.
So oxygen pulse is inversely proportional to heart rate, am I right?
Yes.
How come both are increasing simultaneously together?
That's because of the increase in oxygen consumption. So oxygen pulse, when the VO2 increases steadily, as you know, the oxygen consumption increases, yeah? So oxygen pulse is the amount of oxygen consumed per heartbeat, yeah? And then when these patients exercise, the oxygen consumption increases in proportion to the heart rate. So the oxygen consumption is quite high. So VO2 also increases, and that's why the ratio is higher. That's why it also goes up.
Okay.
So as you know, the stroke volume increases by 6 times at peak exercise, can increase up to 6 times during peak exercise. So it just is a reflection of the stroke volume. Am I clear?
Sure. Thank you.
So far, low peak oxygen consumption at peak exercise indicates a pathology, indicates a pathology. We don't know what exactly it is. A respiratory exchange ratio more than 1.1, 1.15 suggests a maximal test, that we've done a good test, a symptom limiting test. Anaerobic metabolism sets in early in patients with heart failure. An oxygen pulse is a surrogate for stroke volume. I hope that's reasonable. That's fairly clear.
Yep.
Right. I'll just show a few cases and then we'll have for open for discussion. This is a 64-year-old gentleman with recent diagnosis of prostate cancer, but local, not metastatic, but locally advanced. He's treated with local radiotherapy. Now feels tired and breathless. Was referred to a local cardiologist who was my consultant at the time. And inconclusive treadmill test. So he done the exercise for 9 minutes. We're not sure what the test results were because there's not significant ST depression or ST elevation there. So he underwent a cardiopulmonary exercise test. So this is the 9-panel graph. I'll just go back. This is so there are 2 parts in the analyzing cardiopulmonary exercise test. One is through the graphs. One is looking at the graphs, looking at pattern recognition to see. That comes after looking at several cardiopulmonary exercise testing, and the other one is to go through the graph, looking at the numbers, and finding out what's happening. So, looking at the graph here, I've magnified the top right corner graph. I've just magnified it. That's the oxygen consumption. That's the graph we were looking at earlier. The red is the oxygen consumption, and the blue is the carbon dioxide produced. They run parallel to each other, and then anaerobic threshold metabolism sets in. And then it increases steadily, and then a peak exercise. So essentially, if you see this graph, the oxygen consumption steadily increases, but towards the peak, it suddenly abruptly flattens. And this is because of the myocardial dysfunction that sets in during coronary ischemia. And on relief of ischemia at peak exercise, the heart function improves. That's reflected as a sudden slight increase in the oxygen consumption after stopping the exercise. We know that in the cascade of events after during myocardial ischemia, you have perfusion abnormalities picked up by myocardial perfusion scans. Then the systolic dysfunction sets in, picked up by stress echocardiogram, and ECG changes are further late in the cascade, probably around with the symptoms as well. So here you can see we can identify what's happening. It tells us much earlier than the ECG changes sets in. The myocardial, the flattening of the oxygen uptake is a reflection of systolic dysfunction. I would think that in ischemia detection, cardiopulmonary exercise testing will come somewhere in between stress echocardiogram and a normal treadmill exercise test. So this is ischemic heart. Again, looking at 2 graphs from that panel. The one I showed you, this onset of reduction of the oxygen uptake at peak exercise, sudden flattening of the oxygen uptake, and paradoxical increase in the oxygen uptake in early recovery due to relief of ischemia and myocardial dysfunction. And here is the oxygen pulse here, which is in blue here. The heart rate is in red and the oxygen pulse is in blue. It plateaus again, it plateaus towards the peak exercise for the same patient, and then there is a slight increase towards the peak. So he had a coronary angiogram, and then he had a large dominant right with the distal right coronary artery disease, which was stented with relief of symptoms. So this is another situation where we have asymptomatic people coming in with a left bundle branch block pattern. How far do we need to investigate? Is an echo normal? Is a CT coronary angiogram indicated? What are the problems? Is there so I think again in my thoughts there are three problems. One is there a dysfunction in the heart pump itself? Whether the left ventricle is pumping okay, the ejection fraction is normal. The second question is there underlying coronary artery disease which is probably asymptomatic? The third question is there a rhythm problem? Is there a conduction problem here? Is there just a left bundle branch block, or is there any other advanced conduction problem? So she did an exercise test. She did a cardiopulmonary exercise test. This is a different machine, so the graphs, the colors may be slightly inverted. Now, all I can say is the oxygen consumption in the left-hand side panel, the blue, steadily increases and is in the normal range. There is no change, no problems with that. The carbon dioxide production is quite good as well. The stroke volume, which is the oxygen pulse in green here, in the B panel B in the middle, steadily increases within the normal zone as well. And we can do a lot of graphs. You can have about 10 parameters. You can do hundreds of graphs. And this one comes something called oxygen uptake efficiency slope on the right-hand side panel. Again, all shows a normal heart, normal cardiac pump. This all shows a normal cardiac pump. You see the heart rate again goes up nicely. Peak heart rate is about 170. There is no conduction problems. And I can fairly confidently say there is no myocardial ischemia here. There's no plateauing, there's no flattening, there's no reduction in oxygen pulse. I'm quite happy with this lady. I don't think she needs any further investigation. But she did undergo CT coronary angiogram, which was normal. So ventilation is something that we don't normally relate to, but again, measuring ventilation in cardiopulmonary exercise testing is not difficult. As cardiac output is a product of heart rate and stroke volume, ventilation is a product of respiratory rate and tidal volume. An average person who probably breathes about 12 breaths per minute with a tidal volume about 500 mils, ventilation is about 6 liters per minute. That's the ventilation. During the exercise, there is an initial increase in the respiratory rate, anticipatory increase in the respiratory rate when they start to exercise. But after the warm-up period, that settles down. And the initial increase in the ventilation occurs by the increase in tidal volume and the reduction in dead space. Later on, after the anaerobic metabolism sets in, the respiratory rate increases quite significantly, mainly by the increase in the carbon dioxide that's produced from the breakdown of lactic acid. Again, showing here, the breathing frequency gradually goes up, and after the anaerobic threshold, in the top left graph, breathing frequency plotted against time or ventilation, you have the respiratory rate goes up steadily, and towards peak exercise, it goes up dramatically because of the additional carbon dioxide produced. And you have a tidal volume, which is which drives the increase in ventilation initially in the bottom left graph, and then plateaus towards the peak. So by measuring, we can obviously be measuring all the ventilatory parameters. We can identify what the maximum ventilation is. Usually, we stop when normal people, when we exercise, the thing that stops us is not the heart, is not the lungs. Lungs still have reserve. It's usually the heart stops us from doing further. The lungs always have capacity, what we call as ventilatory reserve. And when this ventilatory reserve is less than 10 liters, you can measure that by simple maths by CPEX testing. When the ventilatory reserve is less than 10 liters, it means that the patient has stopped exercising because of the lungs rather than the heart. So desaturation during exercise, we also measure the saturation during exercise. So we can, the desaturation by a SATS probe does not occur until the oxygen, partial pressure of oxygen falls below 8 kilopascals in blood gas. So that's, it doesn't drop normally below 8 until the PO2 of oxygen is less than 8 kilopascals in blood gas. Nevertheless, if it falls more than 5%, it suggests lung pulmonary pathology. So a drop in saturations of more than 5% during exercise indicates pulmonary pathology. The only exception could be pulmonary hypertension. Ventilatory efficiency. This is whenever we read heart failure papers, they talk about ventilatory efficiency. It is this plot, which is the carbon dioxide produced on x-axis against the ventilation against y-axis. Although it looks very scientific, it's not. It just tells us how efficient is a ventilator system in removing the carbon dioxide produced. How efficient is the ventilator system in removing the carbon dioxide that's produced? That's the essence of this. So if someone has to work very hard to remove the carbon dioxide produced, they are using excessive ventilation. That means there is a problem. So this slope normally is about less than 30, the slope of this. If it is more steeper, like more than 30, 34, 40, that indicates an inefficient ventilator system. Either the patient has interstitial lung disease, COPD, pulmonary embolism, pulmonary hypertension, or in fact, it can also be congestive cardiac failure, where the pulmonary circulation is impaired because of the heart itself. So higher VEV-CO2 slope indicates essentially a ventilation perfusion mismatch. This is one of the important things in our heart failure. So again, here you have three slopes. One is a patient with pulmonary fibrosis, where the slope is very, very high in these patients, 63 on the right-hand side. And then you have someone in the orange one, the middle one is someone with heart failure, a slope of 34, and then a normal slope of 23. We can measure that with the help of the machine. So usually it indicates a heart or a lung problem. So desaturation indicates a lung problem. A low breathing reserve indicates a lung problem. A high VEV-CO2 slope indicates ventilation perfusion mismatch during exercise. We saw this graph before. We can use, as I said, we can crunch the numbers and come to a conclusion, but also we need to be careful about pattern. We also need to know some pattern recognition as well. Usually crunching numbers would give us an approximate answer, so we don't need to be expert straight away. I'll give you some more examples. So a 69-year-old lady with breathlessness on exertion, she went to see a cardiologist, and then they did an echocardiogram, which is normal angiogram. Now she comes in. It's a bit in small, but if you see the red panel, this patient, all the parameters, I can tell you the oxygen consumption, the oxygen pulse, all the ventilator parameters were all going normally. But at about 6 minutes of exercise, the patient said, no, I can't exercise more. I'm feeling breathless. If you see the respiratory rate at rest is about 12, at peak exercise, it's about 17. The respiratory exchange ratio was less than 1. So all I can conclude was this is a problem with perception. Patient thinks that she is breathless as soon as she starts breathing faster. So we refer her for some pulmonary rehabilitation for breathing exercises. So this can be a problem where the problem itself is not, as we know, it is good. There's no major problems here, but to reach this diagnosis, she had to go through invasive tests, including angiography. Now, this was a 64-year-old man, previous coronary bypass operation, is a little bit chubby with a BMI of 32, severe aortic stenosis measured by echocardiogram. Now he's breathless. His breathlessness is not sudden. It's been going on for 2 or 3 years, but he says it gradually works. We're not sure whether this is all the valve or not. So he does a test. Now, all the top right panel, the blue is oxygen consumption, going steadily up. There's no problems. It's about 85% of predicted. In here, in the top middle panel, you have the stroke volume reflected as oxygen pulse is going steadily up. There's no flattening, and it's close to normal. And then crunching at the numbers, you can say the respiratory exchange ratio underlined in red in the bottom right-hand side is 1.06. It's not the peak exercise. Usually it's more than 1.1. You can assume it's he has done a symptom-limiting peak exercise. So then you look at the oxygen uptake. It's about 85% of predicted, which is not bad. It's just below normal. And then you look at the ventilation. I can tell you that the ventilator reserve or the breathing reserve is less than 10. And then you have additional parameters which we already have, which we already get it from treadmill tests. The blood pressure steadily goes up. There's no drop in blood pressure. All I can tell is this patient is stopped the test because of possible respiratory limitation, possible COPD, but it doesn't seem to be aortic stenosis is restricting him. And the usefulness is we can repeat the test in 6 months' time and see how it goes. In 1 year's time, see how it goes. We can operate on him, replace the valve, but unlikely to improve his symptoms. So this is a 53-year-old man with family history of hypertrophic cardiomyopathy. His father had a defibrillator. His septum is 13 millimeters. He's fit and well. How do you risk assess this patient? Traditionally, we'll do a treadmill test, Holter maybe, and an echocardiogram. So we did a cardiopulmonary exercise test. Exercise time, 13 minutes and 39 seconds. Fantastic test. His peak oxygen consumption is 150% of predicted. His breathing reserve is very good. His VVCO2 slope or otherwise ventilatory efficiency here is very good, 20.3. As I said, less than 30 is normal. And then his saturation, there's no drop. All I can say is he's doing fantastically well, and all you need to do is probably repeat the test in a year's time or something. So here, difficult case, 67-year-old man with a history of heart failure. History of breathlessness. He's clubbed. He has got ground glass opacification in the lungs. Normal LV systolic function. Ex-smoker, 40 years. Abnormal spirometry with reduced gas transfer, all pointing towards the lungs. Here we have it. 7 minutes of the test stopped due to breathlessness. His peak oxygen consumption is not terribly bad compared to what his other tests have shown. Is 82% of predicted. His respiratory exchange ratio was 1.29. As I said, more than 1.1 is good. It means that the patient has achieved a good test, symptom-limiting peak test. The anaerobic threshold was at 53%. Less than 40% means heart failure. It's not the case. The VVCO2 slope is 41, meaning that he's breathing very heavy to remove the carbon dioxide produced due to lung problems in his case. His breathing reserve is 6. Less than 10 means lung problem. That's his graphs and good. So some unique diagnosis made by cardiopulmonary exercise testing, diastolic dysfunction, difficult to prove or disprove. The only way, I think the gold standard is invasive right heart catheterization along with exercise. Early pulmonary hypertension, right to left shunt that starts an exercise, impaired muscle bioenergetics, psychogenic dyspnea like the patient I showed you. So this is a final case, which is very interesting. I'll show you this and then finish off. A 43-year-old man who's breathless. He has congenital blindness, hypertension, diabetes, and recently he has had some hearing problems as well. So he's been seen by ENT. Now, echocardiogram, mild left ventricular hypertrophy. We did a normal, and angiogram is normal. Everything is normal, but this patient is breathless. So he does a cardiopulmonary exercise test, right? Now, if you see the oxygen consumption is 75% of predicted. So that means he is limited. And I can tell you this respiratory exchange ratio was more than 1.2. So he did a peak exercise test, but we can prove that he's limited. He's not lying to us. He's not psychogenic. And this one, look at this bottom one. So oxygen at anaerobic oxygen consumption at anaerobic threshold, the oxygen at peak oxygen consumption predicted at peak exercise is less than 40%. That shows that it can be either a cardiac problem in delivering the oxygen, which is not the case. We have proven that the heart is normal by echo and angio. Could be a muscle problem, myopathy, mitochondrial myopathy. Now, he did a test, and interestingly, I've magnified the bottom right one this time. This is the end-tidal oxygen and end-tidal carbon dioxide. As you know, the end-tidal oxygen and carbon dioxide are the closest oxygen carbon dioxide levels that we get to arterial blood gases. Now, here, if you see the red line, the end-tidal CO2, it steadily goes up, and here the dotted line is the anaerobic threshold. After the anaerobic threshold, his end-tidal CO2 should drop down, but actually it increases steadily, as if he's insensitive to the carbon dioxide produced. And then, sorry, one panel which I didn't enlarge is the bottom left panel. I'm not sure whether you can see that. It's very small, but hopefully you can see that. The breathing frequency is in orange. That's otherwise the respiratory rate is in orange. And you can see it's very flat. There is no increase in respiratory rate. It's about 20 at peak exercise, despite his blood carbon dioxide going up. So we were a bit confused. Why is he so insensitive to the carbon dioxide produced? So then we thought whether this could be a medullary problem or could be a carotid body insensitivity to carbon dioxide produced. So we thought we will arrange an MRI of but he didn't have any surgery to the neck and no head injuries, no tumor. We thought we need to exclude a tumor. We need to arrange a MRI brain or something like that. But we brought him back for another test. We brought him back for a test with arterial blood gas. So we put an arterial line in. Every couple of minutes we did some arterial gas. So the blue dots in here shows the arterial blood PO2, the partial pressure of oxygen here. It runs parallel to the end-tidal oxygen. There's no problems with it. Here, this is the end-tidal CO2 in the red line, and then the arterial partial PCO2 in the red dots, which runs parallel to it. No problems, we know that. Then, interestingly, look at the lactate. This resting lactate is not normal, more than 2. And then the peak lactate at peak exercise was 15. And then his pH was 7.19 at peak exercise, going up to 7.21 at 10 minutes of recovery. And after 20 minutes of recovery, it's 7.27. Then we realize he's insensitive to carbon dioxide, not likely because of a medullary problem or a carotid body problem, but actually he's producing so much acid in the body is getting used to it. It's very likely that he had a mitochondrial myopathy. He went for a muscle biopsy and was eventually treated. Thank you very much. And this is Carmen Wasserman, who's the professor in cardiac physiology. This is a fantastic book, Principles of Exercise Testing and Interpretation. And this is a course, actually, online course they're running soon, actually, end of November, if anyone is interested. Thank you.
Excellent talk. Thanks a lot, Dr. Parshuraman sir. I had some basic doubt. Has there been any influence of race on the normal values, or it is the same across all races?
Of course, the problem is the normal values is heavily contested. The normal values are always been contested because we need to establish the normal values in each region, each country, or even within the country. Like in a big country like ours, we need to establish normal values in separate regions. That has not been done. We use Western values at the moment. But we need to have do that in each place.
Another doubt is this CPEX testing for perioperative evaluation.
Absolutely. Yes.
for major surgeries.
Yes.
So has it, I mean, so everywhere people talk about it, but in day-to-day practice, people do it in any place on a regular basis?
Yes, well, we definitely have to do it on a regular basis, because in most centers in the UK we do it for major major operations, and smaller centers are catching up. There is strong indication, especially for lung surgeries, lung cancer surgeries, patients going for endovascular procedures, patients going for major abdominal procedures. There is a strong indication for doing cardiopulmonary exercise testing for risk assessment, so that we can inform the patients clearly that this is the perioperative risk. Do you want to take the risk or not? The second thing is to know the perioperative risk, so where we can place them, whether we can place them in high dependency, or whether we need, or whether we can do it in a smaller hospital. For all those reasons, is very useful, and there is a stronger indication. The other field is cardio-oncology. We have all the patients having chemotherapy and whatnot, and we don't know what exactly the functional therapy is. In that situation as well, it will be very useful.
Thank you, sir.
How commonly do you do this test in your practice?
Right. Okay. I mean, I started in Taunton Musgrove Park last year. I'm still in the process of setting it up as a regular service. We have a machine that's been used only occasionally, because I think one of the problems with cardiopulmonary exercise testing is the expertise. People don't want to use it because it's not in cardiology training. It's not in respiratory training probably. So nobody wants to use it. Second problem is the different specialties have a lot of interest in it. Anesthetists have a lot of interest in it. Respiratory physicians have interest in it. Cardiologists have interest in it, but nobody takes ownership in it. But in my opinion, I think we need to, as cardiologists, we have the most experience in doing exercise tests, and we should. But I think it makes sense that we use it regularly. We use it it is in the cardiology department. I would say that we should replace the treadmill test almost. Whenever possible, we should have a cardiopulmonary test.
It hugely varies. So in a centers where I worked in the UK, if you work in a large adult congenital heart disease center, which University Hospital of Birmingham, they have got the largest Fontan population. They really, if you get populations with univentricular hearts and so on, it can be incredibly difficult to establish with normal echocardiogram what is the pump function of the heart. And the best way is really the cardiopulmonary exercise test. So in centers and in the NHS, there are some rules and guidelines where really centers doing adult congenital heart disease should all have the knowledge. So in centers as such, they do have the same as I think every center who does transplant, they have got great knowledge of CPEX. In the smaller centers I worked in Worcester Hospital, was a larger DGH. I have to admit, I was a small user of the CPEX then, having the background used it a bit in my research. But as Satish mentioned, the anesthetists have got great interest. So in the smaller centers, it was more or less used extensively by the anesthetist for new cancer patients, or the other big number of patients was pre-op assessment in patients who underwent triple injury. So I think the anesthetists are in some centers the leading experts, and the rest. Sometimes it was the respiratory department who had the ownership of CPEX. However, as Satish mentioned, I think we as a cardiologist don't have so much expertise, but there is lots of utilization we could use it for.
I at the moment, because of the lack of service in my hospital, I send them to an anesthetist in the next hospital, and the kind of report I get from them is really basic. It's not useful at all. They don't push the patients. They hate to push the patients very hard. Their interpretation is basically number crunching. They don't go into the details of pattern recognition. I think as cardiologists, I think and fantastic for one trial, as we know, the Orbita trial used cardiopulmonary exercise. That's really good. I think in future, for example, if they do a CTOs, whether CTOs are really helpful or not, again, we should have cardiopulmonary exercise testing, because that's a functional way of assessing the patient as to, apart from MACE and everything else, one test could tell you not increase in ejection fraction by 3% or 2% or whatever it is, which is the overall, whether we have made an improvement to the patient status. So I think, I think as cardiologists, we should use it more, and we can be really good at it once we start using it.
Is it possible for me to voluntarily alter the report if I know the mechanics? To start
Yes.
kind of voluntarily hyperventilating.
Yes. So it produces. So we have to do some work on it before the report is published. The report is printed out. So you can print out as such, but obviously the machine does a lot of mistakes. So you have to work on it a little bit, saying that this patient is voluntary, is ventilating too much or something. You can change those things. And for example, the machine picks up the anaerobic threshold at some point. You have to alter that. You have to say, oh, it's not the anaerobic threshold there. It occurs much earlier. And then this is where the point I think it is. And so the machine allows you to do all those things, and most machines allow you to do all those things.
I don't think I think you're muted. We can't hear you.
Bhupati, we can't hear you. Bhupati, you're muted. We can't hear you. You're muted.
Bhupati, voice audible illa.
Can you hear me now?
Yes.
Yeah.
There's a question in the chat box. Dr. Manohar sir, would you like to take it forward?
There's somebody as Dr. Harish is asking whether there are any data prior and post revascularization.
Yes.
Satish sir, you would like to answer that?
Yes, of course. The Orbita trial was the only trial that studied that. We don't have any of the study details on prayer. That's what I'm saying. We need Orbita trial shows no difference in peak oxygen consumption. So that, I mean, you can always go by the exercise time. That's what we used to go by. So the patient exercise for 7 minutes, now 9 minutes or 10 minutes, an approximate number. But the only study that was done properly on this Orbita trial, which is I think well done, isn't it? I mean, with regards to CPEX, is well done anyway.
Okay, sir. Bhupati, you are muted.
Am I audible?
Yes.
Yes, we can hear
Dr.
you.
Manohar sir, would you like to have? Do you have any other questions?
No, I think most of them have been covered. I think.
Thank you, Dr. Constantine. Thank you, Dr. Satish. It was very nice having you here. We sincerely apologize for the internet hiccups what we had during the talk of Dr. Constantine. We apologize for the hiccups, but the talk was very wonderful. It went back. It took all of us to our first MBBS. We read pulmonary and cardiovascular physiology. I'm extremely happy to see my fellow colleague Dr. Satish Kumar discussing about these things. I am very sure he didn't like those topics when he was studying in MBBS. Anyway, thanks a lot, Dr. Constantine. Thanks a lot, Dr. Satish. Dr. Manohar sir, Dr. Murali sir, would you like to add any more points?
It was a great pleasure. Thank you very much for the invitation, and my apologies from my side with the internet connection. I think that's unfortunate, but hopefully you heard at least part of it.
We got what you are. We got the main important points.
I think.
Certainly, very useful talk. Thank you all. Thank you for both the speakers. The fundamental thing, cardiopulmonary exercise. You took us back to Guyton days. We used to read Guyton and Renan. You took us back after Constantine and very relevant. This is what the patient wants. This is what we want. All other interventions are limited if we don't achieve the endpoint that you want to picture in.
Thank you, Dr. Satish.
One more, sir, please.
Well, I just wanted to thank both Dr. Constantine and Dr. Satish for the wonderful talk.
Thank you so much for the opportunity, and thank you, and all the best for Riga Grand Rounds in future.
Thank our assistant professor, who is the main backbone. Without his IT knowledge, this kind of series. Thank you, Preetham. Thank you.
Thank you.
Good evening.